go ahead, sir. Thank you.
Thank you so much. At the outset, I would like to thank all AIOS and all the esteemed panelists for giving me this opportunity. So I'll be speaking on SICS and astigmatism management. So as we all know that there has been technological advances in ophthalmology and it has grown by leaps and bounds. And it is not imperative for us to improve the patient's vision, but also to refine it. And so proper management of astigmatism can lead to excellent visual outcomes and to achieve emetropia is the target nowadays. So the goals of the surgery is mainly painless visual recovery, spectacle independence, correction of the pre-existing astigmatism, repeatability of the surgical results so that our surgically induced astigmatism is, we know it, and to have a sustained quality of vision. So as we all know, types of astigmatism are mainly with the rule and against the rule. Against the rule is one we deal with in all the cataract patients because that is what we see in the older patients. And there are multiple factors affecting the astigmatism, which we will deal with later. But some of them are incision characteristics, the use of cautery, the use and non-use of suture, and proper pre-operative assessment of pre-existing astigmatism should be done. So we measure the astigmatism usually with the help of corneal topography these days, but there are other methods of measuring with the help of retinoscopy and keratometry. And astigmatism usually with manual keratometry is preferred in patients with poor fixation corneal abnormalities, distorted Meyers and highly toric cornea. And in rest of the cases, we, as I've said, we prefer topography. So in SICS, we can manage astigmatism by the incision characteristics. If the size is larger, there may be more greater flattening. If the size is smaller, then there would be lesser flattening. The distance of the cornea is also very important. The farther the incision from the cornea is, the lesser the astigmatism, and vice versa. And the target is always to hit the astigmatically neutral zone. This was a concept given by Koch in 1991, and it was he gave two important equations for it. That surgically induced astigmatism depends upon the length of the incision to the power of cube, and it is inversely related to the distance of the incision from the corneal center. So the funnel's base is at the limbus, and as it moves away, it widens. And the incision which is made should be made within this astigmatically neutral zone. So the type of incision may be superior temporal or superiotemporal. Superior is easy to learn. During our post-graduation time, we usually operate superiorly. There is wound protection with the help because of the eyelids, and there is less foreign body sensation in this case. In temporal incision, it is mainly used where patients have deeper sockets, small eyes, and future trabeculectomy patients. And superiotemporal is the one which gives best of both worlds, and it reduces the astigmatism also, and it is easier to practice. So the site of incision, the flattening effect is achieved at the tissue, and steepening is produced 90-degree away. And this is a phenomena which is known as coupling, and this is the thing that induces the astigmatism. So in other studies by Gokhale et al., they have studied about the astigmatism that is caused by surgical methods according to the location and the incision length. And as we've talked about, superiotemporal was the one in which they found that it had the least surgically induced astigmatism, while superior was the one in which there was the most. So cautery also is very important. In SICS cases, we usually use cautery, and excessive cautery may increase the amount of astigmatism due to scleral shrinkage and scleral necrosis. So how to correct this pre-existing astigmatism? Mainly in cases where there is mild astigmatism, it can be neutralized by changing the site of the incision. We can vary the construction of the incision, and we should always operate on the steeper axis so that it flattens out and corrects the astigmatism. The other method is doing a limbal relaxing incision. These incisions are made at 90% depth at the steeper meridian, which is again very important because we want to flatten the steeper meridian, and in front of the limbus. So this is a case of a SICS in which we are doing a limbal relaxing incision. We make the main port, we make the tunnel. We do not enter the eye. We measure around 6 millimeter, and we make a limbal relaxing incision just anterior to the limbus. So this is a guarded knife which makes the incision around 600 mm. And there are multiple calculators and nomograms which can be used for limbal relaxing incision. There is also a online calculator with the help of which we can do calculations. And the main thing is that we have to operate on the steeper axis and have to apply the limbal relaxing incision also according to that. So 90-degree off is the most common error, and it is imperative to check the calculations. So these are the other nomograms which are used. We can vary this according to the patient's age. In a younger patient, we have to make a larger incision, and in an older patient, we make a smaller incision. And usually 30-degree of paired incisions correct around 1 diopter of corneal astigmatism. So these are other nomograms which are given by Gill, and this is another nomogram. The advantages of limbal relaxing incision is mainly that there is less tendency of shift in the resultant cylindrical axis, is less chances of irregular corneal flattening and irregular astigmatism, and it is easier to perform than shorter and centrally placed corneal relaxing incisions. And paired LRIs exhibit consistent 1:1 coupling ratio, as we talked about. Other method is opposite clear corneal incisions. This was a method given by Liver and Ahn, and they added an identical incision on the opposite side. And the mean astigmatism corrected with the help of this was around 1.66 diopter. The technique involves mainly creating two biplanar incisions. This may be used in phacoemulsification, and in SICS also we can make another clear corneal incision on the other side. But again, this has a lack of predictability. There is absence of any nomogram, and there are increased chances of endophthalmitis in these cases. So, in short, if there is pre-operative astigmatism, if there is a low astigmatism, we can make a frown incision 3 millimeter behind the cornea at the astigmatically neutral zone. In moderate cases, we can make a small incision centered along the steeper meridian, about 6 millimeter, and straight in relation to the limbus, because that may also change the amount of astigmatism corrected. And in high cases, we can do a combination of spherical small incision profile with limbal relaxing incisions. Post-operatively, we can okay, I'm just finishing. In post-operative cases, we can do astigmatic keratotomy. We can do a wound revision, and or either excimer laser. So the take-home message is that careful identification of astigmatism magnitude and meridian should be done both pre-op and intra-op. Uh, the, there's a step ladder approach for this, which we've already talked about, and we should always proceed according to that. And
Pranav, can you
techniques can
please
be effectively
summarize?
combined for higher levels of astigmatism. And again, once more, always apply the incision on the steeper axis. Thank you so much.
Thank you,